let's go ahead and get started. Good afternoon, everyone. My name is Carrie Finley, and I'm joined by Andrea Boucher, and we're very happy to be here to discuss the importance of managing patients with hypertension in a skilled nursing facility. A little bit of background about myself. I am a registered nurse, and I'm a project specialist at Superior Health Quality Alliance. And I'll have Andrea do her introduction when we get to her section of the presentation. Next slide. So at the conclusion of this presentation, it's our goal that you'll have at least one takeaway or a resource that you can share with someone else within your organization. And we hope that we'll be able to have an interactive discussion about the importance of hypertension in an aging patient population, and also learn about some of the reasons why hypertension occurs and how we can, most importantly, accurately measure blood pressure to manage hypertension. Next slide. Okay, so I know this slide's a little bit busy, but to start us off, I think it's really important to discuss why hypertension matters. From reviewing the slide, currently, more than 1.4 million individuals live in 15,500 Medicare and Medicaid certified nursing homes across the nation. So now, according to the Centers for Disease Control and Prevention, nearly half of adults in the United States have been diagnosed with hypertension, and this prevalence increases in age. So 3/4 of adults aged over 60 have been diagnosed with hypertension. And the National Center for Health Statistics reported that about 80% of residents in skilled nursing facilities have hypertension. And we know these numbers are expected to grow. There's no denying our population is aging. And by the year 2050, it's predicted that the number of adults age 65 and older in the United States is projected to nearly double. And the number of adults 85 years and older is expected to triple. So with the growing number of older adults, it's estimated that 27 million adults will receive nursing home or home-based services by the year 2050. And as a result, there is a critical need for guidance in managing chronic diseases such as hypertension in the nursing home population. Next slide, please. So what we thought we'd do is we take a moment to answer this question. So the question that we have for you today is, are hypertension treatment and control rates better in elderly patients who are in long-term care settings than in patients who reside in the community? So I'll give you just a few moments to think about that. And then if you would like to enter your answer in chat, just enter either yes or no, what your thoughts are on this. So I'm going to watch chat and look for your answers. Hey, I see some yeses coming through. We'll just give a few more moments here. Okay, well, for those of you who answered yes, you are correct. The answer is yes. Hypertension treatment and control is better in elderly patients who are in long-term care settings versus the community. Next slide. So I want to elaborate on that a little bit. There's several factors that contribute to better blood pressure control. So the overall factor is healthcare staff advocacy. Residents in long-term care settings have access to healthcare staff who can ensure that they have the care that they need. And this includes access to medications. So having access to pharmacy, or in some settings, an on-site clinical pharmacist, helps to ensure that residents have the right blood pressure medication dose and are receiving the medication at the right time. This might not be occurring consistently in a community setting. And there may be social determinants or social drivers of health barriers as well to obtaining those medications or ensuring that the medications are taken at the right time or the right dose. Also, There's consistent and continuous nursing attention and monitoring, and this helps to ensure that blood pressure is being well managed through regular blood pressure readings to ensure that the blood pressure is within the healthy range. In addition to ongoing physician follow-up and continuity of care. And we're finding too that residents in long-term care settings are more likely to adhere to their treatment plans, which helps to ensure that their blood pressure is well managed. And we know that these factors are crucial for ensuring that our residents are receiving the care they need to manage their blood pressure effectively. Even residents who do not have a diagnosis of hypertension, it's important to have an ongoing and consistent monitoring due to risk factors. And my apology, I wish I had this on another slide, but I don't. So those risk factors are, we have our modifiable risk factors, such as lack of physical activity. There might be an unhealthy diet or one that's too high in sodium, being overweight or obese, drinking too much alcohol, sleep apnea, smoking and tobacco use, and stress all can contribute to hypertension. And then we have those risk factors that are out of our control, such as age, gender, race, and family history. Next slide, please. So I just wanted to take a moment. I know I previously very quickly went through some of the risk factors, but I wanted to focus on one of the risk factors that we can't prevent, and that's age. Our natural aging process can impact changes in our blood pressure. So according to the National Institute on Aging, as we age, our arteries tend to get less elastic and more rigid, and that can cause the blood pressure to increase. As you can see from this graphic on the slide, we have young, elastic arteries. They tend to expand and recoil as the heart pumps blood. And this really helps to buffer energy from the heart, and it drives blood to the rest of the body. However, as we age, those walls tend to just naturally stiffen and thicken. And though that can cause an increase in pressures, it can alter the flow of blood in ways that can damage those downstream organs. So stiffer arteries that don't dilate well increase our risk for heart attack, stroke, and other cardiovascular diseases. So what I indicated in this slide is that until the age of 50 to 60, both our systolic blood pressure and our diastolic blood pressure, they tend to increase naturally with age. However, over the age of 60, in the majority of cases, the systolic blood pressure can tend to still continue to increase while the diastolic blood pressure remains stable. Even can decrease a little bit spontaneously. And that, the most common cause or that change actually is due to the thickening of the arteries or arteriosclerosis. Other factors can also contribute, such as atherosclerosis, and that is the buildup of fats, cholesterol, and other substances, so like our diet, in and on the artery walls, which can also impact blood flow. So now we have arteries that they're thick and stiff, and now they're clogged. And so all of this can really increase our blood pressure. And then I should mention too, atherosclerosis, it's like a specific type of atherosclerosis. And again, all of that contributes to elevated blood pressure and the risk of heart disease, stroke, heart attack, and other cardiovascular diseases. Next slide. I guess I would be remiss, we can go back one. I guess I'd be remiss to, if I'm mentioning arteries, I should also mention the heart. In addition to arteries stiffening and thickening, age can also cause a similar impact to the heart. So we have age-related specific changes to our electrical system. This can lead to arrhythmias, which is like a rapid, slow, or regular heartbeat. Our heart valves, which are, our one-way door-like parts of the heart that open and close to control blood pressure, those can also become thicker and stiffer. And stiffer valves can limit the amount of flow of blood throughout the heart, and they can also become leaky, which can result in the fluid to build up, and then also to increase like swelling to the lungs, and then you'll find that in our lower extremities too, like our legs, feet, and abdomen. The chambers of our heart can increase in size, and the heart wall can thicken. So the amount of blood that a chamber can hold, even though the heart itself is bigger, the amount of blood the chamber can hold decreases. And so the heart may fill more slowly. And then, interesting enough, long-standing hypertension actually is considered the main cause of that increased thickness to the heart wall. So that can cause AFib or atrial fibrillation, which is a common heart rhythm. And then I thought important to mention too, increased salt sensitivity. So I mentioned one of those modifiable changes we can make. With increasing age, we know people become more sensitive to salt, and that can also contribute to an increase in blood pressure, or you will notice like the ankle foot edema. So I just wanted to throw that little caveat in as well. Next slide, please. So at this time, I'll hand it over to Andrea.
Thanks, Carrie. And just to quickly introduce myself, I'm Andrea Boucher. I'm a quality improvement advisor with Superior Health based out of Michigan. So we do have a second chat question for you. And that is, how do you assess your staff's competencies on blood pressure auscultation? So feel free to add a response in chat. Some examples might be if you have a specific policy or procedure. Is there a specific frequency that you're assessing competency? So while you're entering your response in chat, I'll go over some of the resources that are available to you that we have linked on this slide. And these would be beneficial in creating a process for assessing staff competency and blood pressure measurement. The first link is the Target BP webpage. So this reviews the steps to measure blood pressure accurately and deeper dive into what we're covering today. There's also resources like a blood pressure measurement policy and procedure template available through Target BP. This is a great starting point as a template that you can revise and include your facility's specifics for blood pressure competency. There's also a technique quick check available. This is a resource for determining if clinicians are taking blood pressure measurements the right way, in the same way every time. Achieving all of the patient preparation positioning, we know that that's very hard in the nursing home setting, but it's really important to be aware of what all of those pieces are, so that you can adhere to as many of them as possible and cover all of those pieces as much as possible. So that technique quick check tool is not designed to assess individual competence. Instead, it's going to help detect any systemic issues that you might have in your facility that could be resulting in the routine use of improper technique. And then lastly is a staff competency for manual office blood pressure measurement through the American Medical Association. This is a competency checklist that can be used at your facility as well. So if you do have any ways that you're assessing staff competencies, we would love to hear what those are. So I don't see any in chat yet. So if that's not something that you're currently doing in your facility, that's definitely something that we would recommend doing at least on an annual basis. Next slide, please. All right, so we can't diagnose, treat, or manage a resident's high blood pressure correctly if we're not capturing them correctly through the way that it's being measured. Making sure that we take a resident's blood pressure correctly on every resident every time is really essential. These accurate measurements lead to a correct diagnosis if a resident is not currently diagnosed with hypertension. That blood pressure is used to initiate treatment and monitor the effects of drug therapy. It's also helpful to achieve timely and effective treatment, routine monitoring if that resident has been diagnosed with hypertension, and also medication adherence. So if we are missing elevated or underestimated and misclassifying the readings, that could be interpreted as a false normal level and lead to the undertreatment of the patient's blood pressure. That could potentially lead to more organ damage for that person. And on the flip side, if you're overestimating or getting a false high reading, that could potentially lead to overtreatment, the possibility of drug-induced side effects. So it is really important to use proper techniques so that your readings are consistent and reliable on every resident every time. Next slide, please. So what impacts a resident's blood pressure? There are a couple of different ways to look at this. So you have patient factors. These are the things that we cannot always control. And then the measurement factors. So this is the piece that we would really look at to cover in a competency training so that you're making sure you're measuring, again, the same way every single time. So the patient factors are white coat hypertension. So for example, if a resident is not comfortable with medical professionals coming into their room and having their blood pressure measured, maybe that's causing an increase in their blood pressure. All of these different emotions, such as nervousness, stress, anger, if they are sick, if they're experiencing any pain, or if they're just having a long time to wait, these are also going to impact their blood pressure. As Carrie mentioned, there's certain demographics that we obviously cannot control, such as age, sex, race, and ethnicity, that could impact blood pressure. And then specific lifestyle pieces. So lifestyle modifications are usually that first line of defense. Once a person is diagnosed with hypertension, it's usually recommended to make changes to diet and exercise. So obviously, if a person were to have poor diet and exercise habits, that could impact their blood pressure. If they are using any substances, such as smoking or alcohol, that can also impact their blood pressure. Also, any caffeine intake, if they're taking a decongestant, like I said, if they are sick, any over-the-counter medications and nicotine use can also impact their blood pressure. And then if they are talking while the blood pressure measurement is being taken, that could cause their blood pressure to be elevated. So on the flip side, like I said, those measurement factors, those pieces that we can control, this is where you'd really want to focus your efforts on making sure you're taking blood pressures accurately, making sure the patient is positioned correctly. Like I said, we know that that's very difficult in the nursing home setting. So as much as you can to get the patient in the right position, seated in a chair with their feet, both feet flat on the ground, their back is against the back of the chair, their heart or their arm is at heart level. So those are all pieces that you can try to do to capture blood pressure correctly. If there is air in the blood pressure cuff before measuring, that can cause an elevated reading. And then if using the correct cuff size, so if you're using a cuff that's too large, that could potentially underestimate that person's blood pressure. Or if it's too small, that could overestimate it. So you want to make sure you're choosing the correct cuff size. It's not a one size fits all. And if the cuff is unevenly wrapped around the person's arm, it could potentially come undone upon inflation, but it also could lead to an incorrect reading. For taking a blood pressure manually, if you're deflating the cuff too quickly, you may not be capturing the systolic and diastolic readings at the correct spots. And then not inflating the cuff high enough or too high. So this is a piece where we say, you don't want to just blanket inflate everyone up to 200. You want to make sure you're doing it on an individual basis. So typically what happens is you can take maybe a person's previous, 3 blood pressures. Maybe their systolic blood pressure is usually 140. So you can go 30 millimeters of mercury above that to capture their blood pressure correctly. So that way you're not causing any pain that, maybe inflating them to 200 would cause a little bit of pain for that person. The auscultatory gap, so this is when the pulse disappears and then it reappears while deflating the cuff. So there could be potential for improper interpretation of this gap. So that could lead to those blood pressure monitoring errors. So typically what you see here is an underestimation of systolic blood pressure or an overestimation of diastolic blood pressure. So it's important that you're deflating the cuff fully and making sure you're capturing those readings at the correct spot. And then again, the last one for manual measurement is looking at the gauge at an angle. You want to make sure that that gauge is properly placed and positioned so that you can see it correctly and see where those systolic and diastolic readings are. Next slide, please. All right, so we know that antihypertensive medications and lifestyle changes have been proven to reduce blood pressure. But over the last few decades, there's actually been evidence of alternative approaches to lowering blood pressure. Meditation is one of them, including mantras, training awareness, mindfulness, transcendental meditation. So typically, these types of meditations relate to improving awareness or improving consciousness. So it's been suggested that those mechanisms could lead to reductions in stress, reductions in physical arousal. So that could produce favorable effects on the nervous system and in turn, potentially lower blood pressure. Also yoga and other relaxation techniques. So really the aim of this is kind of like a cessation of mental activity. So bringing a sort of calmness and an attainment of superior consciousness. So again, kind of decreasing that stress level. Again, similar with meditation, could lower blood pressure. There's also exercise-based regimens that could include aerobic exercises, dynamic resistance, and isometric resistance exercises. So the general health recommendation is to perform moderate or high intensity exercise for at least 30 minutes on most days per week to achieve a total of 150 minutes weekly. And that also likely applies to lowering blood pressure. A couple of other ones are music therapy, so using some forms of audio relaxation, and therapy animals. So if you have, anxious residents and they are exposed to therapy animals, this could allow them to experience slower breathing while doing that interaction with the therapy animal. And it actually has been found to boost the immune system as well. So those are some good opportunities outside of medication to help improve blood pressure. Next slide, please. So this slide highlights the consequences of high blood pressure on the body, especially if it's left untreated. The first one is stroke. So high blood pressure can cause the vessels in the brain to burst or to clog. Also vision loss by straining the vessels in the eyes can cause heart failure, causes the heart to enlarge and to fail to supply blood to the body. Heart attacks, because it could damage arteries and cause blockages. Kidney disease by damaging the arteries around the kidneys, and also sexual dysfunction, both in men and in women. So really what we're trying to get down to here is that blood pressure checks are really that first step in identifying high blood pressure in a person, and then also avoiding potentially deadly consequences by making sure that they're receiving the right treatment because their blood pressure is measured correctly. Next slide, please. And I will go ahead and turn it back over to Carrie.
Okay, thank you, Andrea. So to expand a little bit further on the consequences of high blood pressure, what do we know about hospital readmissions and emergency department visits related specifically to hypertension? Well, first, we know that Medicare beneficiaries tend to have complex health concerns, and that those that reside in long-term care facilities are older, more frail, and their medical histories are also more complex. Therefore, it's more than likely that they will experience a hospital admission that may perhaps be unplanned as compared to those in the community. Also, I just wanted to point out hypertension is typically a secondary diagnosis for hospitalization or D-visit, emergency department visits. Patients with hypertension, they're more likely to be admitted with other conditions such as coronary heart disease, heart failure, or stroke symptoms. However, according to data provided by CMS, the Centers for Medicare and Medicaid Services, When reviewing trends for acute hypertensive episodes, there was a marked increase in initial hospitalizations like over a 10-year period. And I believe the study was, 20-year period from 1999 to 2019. So an acute hypertensive episode, that would be like one of the following. So malignant hypertension, a hypertensive heart disease, hypertensive renal disease, a hypertensive emergency or crisis. And this data included all Medicare fee-for-service beneficiaries, so not necessarily within a long-term care facility, but the absolute increase was most pronounced among Medicare beneficiaries that were African American, older than 85 years, and women. So the overall trend was consistent nationwide, although they found that counties more in the South, traditionally in what's called the stroke belt, had the highest rate of hospitalizations for a hypertensive episode. And then when digging a little bit further, for looking at 30-day and 90-day readmission rates, surprisingly, among those beneficiaries hospitalized, the readmission rate did decrease just slightly. So the takeaway from this is we know our Medicare beneficiaries, they're living longer, they have complex health needs. At a certain point, they may be more frail and challenged to manage their health. So just to be aware that hypertension typically is that secondary diagnosis for hospitalizations, hospital readmissions, and emergency department visits. Next slide, please. Yeah, so as I had mentioned, our aging adults are more complex. And I just really wanted to take a moment to review how hypertension, it just impacts so many systems in our body. I mean, as Andrea alluded, we have those consequences of high blood pressure. As this slide states, it's all connected. So hypertension, diabetes type 2, and chronic kidney disease, they're kind of like our triple threat. But few people really think about it until they're forced to. So I really wanted to stress like the interplay between diabetes, high blood pressure, and chronic kidney disease. It can be really challenging to understand, but understanding how they're connected truly is the key to reduce that risk or slow the progression of these conditions. So we know that more than 34 million people, or about, I think it's like 10.5% of the US population, have diabetes. And this is according to the Centers for Disease Control and Prevention, or the CDC. So most cases are type 2 or adult onset. And when someone has diabetes, you know, they can't make or they can't use insulin as well as they should. And so this causes blood sugars to rise. And then that leads to all sorts of complications throughout the body. And it also impacts our small blood vessels. And this can result in hypertension. And it can also result in kidney disease. So we have like this vicious cycle. Diabetes causes our kidneys to become less efficient at filtering blood. And it also causes our blood vessels to stiffen. And then that leads to high blood pressure. And then our high blood pressure accelerates kidney disease. And as a result of accelerated kidney disease, we also have worsening high blood pressure. And then alarmingly, all this is happening, and it tends to be like an invisible cycle. So most people with type 2 diabetes, they don't typically receive a diagnosis, and they don't start taking a medication for about 5 years into their diabetes. And high blood pressure is infamous. It's the silent killer. We call it the silent killer for a reason. And we know kidney disease typically has no symptoms until it's almost end stage. So according to the CDC, an estimated 37% of US adults with diagnosed diabetes also have chronic kidney disease. And then we have the National Kidney Foundation. They estimate up to 40% of people with type 2 diabetes eventually will develop kidney failure. And hypertension, diabetes, type 2, and kidney disease is most common in people aged 65 years and older. So we have that. But then we have a little bit of good news. And I guess I just want to circle back to that initial polling question that we had. And the polling question was, are hypertension treatment and control rates better in elderly patients in long-term care settings versus patients who reside in the community? And our answer was yes. So our takeaway is that managed hypertension, it helps to like offset, or in often cases by the time they get to long-term care setting, is to like delay some of those impacts of type 2 diabetes and chronic kidney disease. And also, I guess a takeaway, and this is probably like a completely separate presentation, but is just, consider the ways in your facility, how you educate patients and how you promote lifestyle changes with your residents. I mean, it's never too late, using a patient-centered approach. So I would ask yourself to think about that. So next slide, please. Yes, and then we wanted to share a little bit about why are vaccines important for those with hypertension and chronic conditions. And essentially, chronic disease, it can make it harder for our immune systems to fight infections. So, vaccines definitely can help to fight those infections that vaccines have been created for. We also know that those with hypertension and chronic conditions are more at risk for serious complications from an illness compared to people without. Immunizations provide the best protection against vaccine preventable diseases, and it's one of the safest ways that we can protect our residents, ourselves, and our families. Next slide, please. And then also, as I mentioned, it protects us, it protects our loved ones from common and serious diseases. There's potential costs of getting a disease, which includes serious health effects, time lost, and financial costs. So definitely vaccines are essential in preventing that. And I think most importantly, oftentimes those with chronic conditions, if they contact disease, it can actually worsen that chronic condition. So we just wanted to make those talking points, make that aware to you. So next slide. Okay, so at this time, Andrea and I are open for questions, if there are any questions. Or we can circle back if you had time to think about that initial question that Andrea had mentioned, which is regards to how do you assess your staff competencies on blood pressure auscultation. I didn't know if anyone has comments at this time.
I asked in the chat if anybody uses that during their skills fair, or if they're continuing to have nursing skills fair for their nurses and their CNAs and people that are providing care.
Oh yeah, excellent question.
And it looks like we did have one person said that they are having their skills fair for both of these for blood pressure monitoring, or I shouldn't say monitoring, for blood pressure competency. And I do, to go on that question too, what is the majority, like who takes the majority of the blood pressures at your facility? Working with different homes in the past, I've seen nurses that do it, CNAs, a combination. I'm just curious what it is in your facility, and actually even a little further, why? Why is it that maybe all the nurses take the blood pressures and not the CNAs, or vice versa? What's everybody doing out there?
We have a question. What do you recommend for a BP cuff if a manual is not available? What is a good and more accurate alternative?
And I see here, oh, sorry, I was just looking at the chat and I saw, okay, CNAs mostly take our blood pressures. Okay.
And then there's another one. Sue Len said that a combination of CNAs and nurses as well.
Yeah, as far as if a manual device is not available, you can use an automated device. One resource that we found really helpful that has recommended devices is a website called validatebp.org, and I can put the link to that in the chat. But it's devices that have been validated for their accuracy. So those would be the ones that we would recommend.
Krista said that nurses will follow up if concerns or if medication related to the blood pressures, but most of the CNAs take them. There was a push not too long ago for CNA classes to be level 1 and like level 2, which level 2 included having a little bit more advanced skills such as vital signs, and level 1 CNAs weren't taught vital signs. So I know that was in Wisconsin, but I'm not exactly sure if that's everywhere or if that's still currently going on or practice.
Know that, Constance. I wasn't aware of that, at least not in Michigan. I am aware of that.
Yeah, it was about, I want to say 5 or 6 years ago, when I was a DON at a facility, and most of my CNAs that were coming out were only the lowest level. I don't know if it was level 1 or advanced or whatever they called it, but I wasn't aware that that was the practice that was actually happening. So I actually had to teach competencies on blood pressures for almost all of my CNAs. We did have another question, I think. Do you include cleaning of the cuff between use in your policies?
Yeah, that's also another great comment. I guess if anything, go back to your blood pressure policy sometime within this week and review it with the resource that Andrea provided to see if you feel like you're on point with your current standards and the standards that we provided you today.
Policies usually include how often they should be replaced, things like that.
Cuff size, it was something that we struggled with at one time. It was just like, it was mostly education from our CNA staff, because it just, whatever cuff was on the blood pressure machine, that's what they use, and not realizing the differences in size and how it affects blood pressure. Just take a look at that too, if that's something maybe might be your issue. We just had to make sure we had multiple blood cuffs on the machine so that it was easily accessible. You didn't have to try to find one.
Yeah. That goes more especially towards the ability to efficiently be able to do your job. Then there was the, do you recommend to include random audits of skills?
I think if it's feasible, definitely would recommend that. I've done this a lot in the physician office setting, and have come to learn that, you can do a blood pressure correctly in a classroom-like setting, but when it comes to the real world and dealing with patients, and in this case, residents, that might not always be the case. So if there is the possibility to do kind of like we've talked about, like secret shoppers, in physician offices, having like fake patients and assessing blood pressure. So if you have the feasibility to do that, would definitely recommend to do so.
And Janice said, many homes use the vital machine with an attached basket. Great place to put cleaning wipes for staff to use. And then question, does your long-term care facilities have a pediatric and a large habitus blood pressure cuff? think that was asking the group.
Mhm.
Yeah,
We always
just,
carried
yeah,
all
right.
sizes that helped, especially the pediatric, because, you know, women, little tiny women that are elderly, and they have really tiny arms, and you can go all the way up to, you know, 3, 4 plus sized women, men, that you need to be able to have all of the sizes. Because it won't be accurate if you don't have one that fits them. Okay, if there aren't any more questions, I just want to give some housekeeping items. My name is Constance, and I was joined by some of my colleagues today, as well as our guest speakers. I'd like to thank them, Carrie and Andrea, for giving this amazing presentation. Just so you know, we host these 1-hour sessions on the 2nd and the 4th Wednesday of the month. Our next roundtable is on December 6th, and it's Dr. John Milkey. He'll be discussing, or I should say, John Milkey did a very nice presentation on invasive group A streptococcus in long-term care. There's a marked increase in prevalence of IgAs in the community, and thus a topic of interest for skilled nursing facilities, as surveyors are being increasingly attentive and are pointing out some of the best practices that have slipped through the cracks over time. We also will be ending our 2023 season on December 13th because of the holiday season. And just as a reminder, we do learn from you guys. Every question that you bring in help us to learn. We learn from the speakers and our peers. So we appreciate all the resources that our speakers have given us and the strategies, and we appreciate and encourage you to support each other through the hour we had together. And we want to thank you for coming today. And there will be a copy of the PDF, but as well, there is a survey. If you wouldn't mind taking the event evaluation, we'd appreciate it. Thank you.
Thank you.
Oh, I also want to send out a reminder that if you are in need of a mobile COVID-19 vaccination clinic, please reach out to the immunizations at superiorhealthqa.org email. Immunizations at superiorhealthqa.org. It's in the chat.
Before we go, any last questions? Any last questions on blood pressure, hypertension, anything you're experiencing, doing? We got a few more minutes here. So if there's anything else you'd like to bring up as you're jotting down the immunization email, give you time there.
Kim, if you'd want to advance the slide one more, we do have some additional resources listed as well. One is our frontline forces module, proper technique for blood pressure measurement. And that is just an excellent module that goes over proper technique and reviews some of the topics that we discussed today. And then also we included 2 nursing care plans, which are great overviews of hypertension and different hypertension interventions that can be utilized. So those are some additional resources that may be helpful.
Okay, well, perfect. All right, and if you'd like to continue this conversation at Superior Health Connect, go ahead and scan this QR code and you can be part of our shared learning environment. And we have different topics in Superior Health Connect for you to be involved in. So we do appreciate your input, your time, and I hope to see everybody again on, like Constance said, December 6th. I almost forgot, December 6th. Again, thank you, everyone.